Good afternoon, everybody. As Alan said, my name is Bob Constantine. I'm with the Florida Mental Health Institute at the University of South Florida. They require I say that at the beginning of every presentation. The kind of umbrella title for the presentation today is the Medicaid Drug Therapy Management Program, Quality Improvement for Psychotherapeutic Prescribing. This program that I'm going to tell you a little bit about is conducted by the Florida Mental Health Institute at the University of South Florida, and it's under a contract with the Agency for Healthcare Administration, which is, I'm sure you all know, the state Medicaid authority for the state of Florida. Okay, what we're going to try to do in the next hour to hour and 20 minutes, just a few brief comments about the background, what created this thing called the Medicaid Drug Therapy Management Program, brief description of the program activities, the things that we do to try to improve quality. We're going to focus particularly on medication guidelines for children and maybe a little bit for adults if we have time. And then hopefully get some input from you all about what is and isn't useful, both in terms of the content and the look and the specificity of treatment guidelines, but also some of these other interventions that we've been doing now for a couple of years. So this background goes back to 2005, actually goes back a good bit longer than that. In the late 90s and early 2000s, when I spent a lot of time down at the Florida legislature, there was, and I believe this is still the case, a sort of clash of forces. On the one side are the anti-mental health drug people, and probably the most vocal and definitely the best funded of that group is the Church of Scientology. But there are also a lot of attorney, child advocate type people that take fairly radical anti-medication positions, particularly with regard to children. The media occasionally picks up on that. I remember in 2004, 2005, there was this huge spread in the Miami Herald about kids in foster care and they're getting antipsychotics and they're having horrible side effects and that sort of thing. So the media attention, at least from my point of view, sort of leans towards the opposition to the use of medications with children, although if a media person was here, they would probably claim they're more balanced than that. On the other hand, there's the consumer and professional perspective. You know, you talk to parents of kids with severe emotional disturbances, and very few of them are anti-medication. I mean, they want the right medications. They want to be able to cope with side effects or minimize them, but they couldn't live, and they don't believe their children, in many cases, could live without medication. And then the professional community that, of course, uses medications and is educated about them and such. So those two forces in 2005 clashed again, and the outcome of it was they created the legislature, rather than restricting access to psychotherapeutic medications for kids, which was the agenda on the table, they created this Medicaid Drug Therapy Management Program. So it's actually created in statute. That number on the top is the Florida statute citation, if you all want to go look it up. The summary of what the legislature says about this program is we're supposed to improve the quality of behavioral health drug prescribing, improve patient adherence, reduce clinical risk, and lower cost. We've been doing this now for mostly on, but on and off for probably 5 years. The lower cost moves in priority. You know, it's listed last here, and actually, if I remember correctly, it's listed last in the statute. When the statute passed, expenditures on mental health drugs was important. It became less important in the subsequent years because mental health expenditures leveled off and actually started going down some. It's now higher up on the list in terms of priority because of the budget squeeze and the reality that second-generation antipsychotics, for example, are the biggest ticket expenditure item in the entire Medicaid pharmacy program. So they are interested in psychotherapeutic medications. Just a quick review of the program activities that we've tried so far. You'll hear a lot more about the medication treatment guidelines, so I won't belabor that too much. Decision support tools. I don't know whether any of you have been exposed to the gold standard PDAs that allow you to access through a PDA, and there's also a desktop application, 100-day drug histories of any patient in the Medicaid program. You can look to see if there's duplicate therapies, what other physicians are involved with the patients. You can check out adherence because you can see what prescriptions have actually been filled. There's also information available on drug interactions, and our guidelines are programmed into those PDAs, and that the program that creates all that is called EmpowerX. So any physician in the Medicaid program can register either with the PDA if they have one, those are limited, or just using their regular computer and access all that information. And the people that have it and use it find it very useful. We've been trying to enhance the use of it, particularly the e-prescribing component, because there's accumulating information about how that reduces expenditures and reduces clinical risk and that sort of thing. It's been kind of a tough road to get physicians that are initially disinclined to pick up new technology to adopt it. What we started to do is, in this current year, is sign contracts with 4 or 5 community mental health providers and get the organization committed to their physicians using the e-prescribing functions. And then we go talk to the physicians. And there's some physicians that are interested and some that are not, but we have an organizational push behind us. And the number of e-prescriptions that have been generated by this program have increased by thousands of % just in the last 6 months because of that organizational kind of backing. The experts that develop the guidelines also develop what are called edits that allow us to look at pharmacy claims and identify something that might be a problematic prescription. And I got to emphasize might, because we're looking at pharmacy claims. There's lots of information that's not there. What we have done for the last few years is identified physicians that wrote a lot of scripts that hit these edits. So if you just wrote one script that's unusual, you shouldn't get a letter. But if you've written 50 in a quarter, you might very well get a letter. And the letter says, we've analyzed the pharmacy claims. We see you've written 25 prescriptions for 2 antipsychotics for these patients. We're, in the light of the evidence base and the guidelines, we're asking that you take another look at those. Here's the downside of antipsychotic polypharmacy, that kind of communication. We follow that up with peer-to-peer consults and actually do medical records reviews where there are a lot of those prescriptions and the initial read makes us concerned that there are actually safety issues. And so we've gone in, we've extracted information from medical records in some physicians' offices, and indeed have found some, and this is not my judgment, we've had child psychiatrists review the treatment regimens, and some practices that are out there are in fact dangerous for kids, and ACA is kind of struggling to figure out what to do with that. And then the last is measurement-based care. For the last 3 guideline development panels that we had, we bring in these very well-known national experts, psychiatrists in particular areas, and every time they talk about using the guidelines, they keep emphasizing that you have to measure care, you have to measure symptoms on an ongoing basis, or you're kind of wasting your time, because if you look in the record, you do not see the kind of detail that would really help you structure the next thing you need to do. Patients are not always particularly disclosing or maybe even able to disclose. So we've got, again, some projects with community mental health centers trying to get them to adopt specific instruments that are reliable and validated and to use them periodically and put that information in the medical record.